Hi there, and thanks for joining us. My name is Jeff Bell, and on behalf of McLean Hospital, I'd like to welcome you to yet another episode of our educational webinar series. Our focus today, PTSD and other trauma-related disorders. Over the next hour, we'll talk a lot about what these disorders are, but we'll also share how to recognize their signs and symptoms, understand their causes, and explore their treatment options. And as always, we'll do our best to pass along some important resources as well. Here to help us with all of that is Dr. Heidi Brown, a board-certified general adult psychiatrist with expertise in both trauma spectrum disorders and OCD. She is the Associate Medical Director of McLean's Hill Center, a clinical program specializing in the treatment of trauma-related disorders. Heidi, thanks so much for your time today.
Thank you so much for having me, Jeff. It's great to be here.
We are thrilled to have you with us. Before we start getting into the specifics of this topic, I think it would be really helpful to have you paint the big picture of things for us. Let's begin with this. What is a trauma-related disorder?
Absolutely. So a trauma-related disorder, as you might imagine, sort of involves the individual having experienced a trauma being sort of an incident or experience that has a potential to cause kind of significant distress or harm to the individual's physical or psychological well-being. And I think what's important to note is that sort of trauma to some extent is in the eye of the beholder, meaning that what might be traumatic for one person might not be traumatic for another person and vice versa. And trauma can include kind of a wide spectrum of experiences. I think people, classically maybe associate PTSD with combat, war experiences, which is certainly one type of trauma, but also includes potentially a range of other experiences, things like natural disasters, accidents, acts of violence, terrorism, and combat exposure, of course, sudden loss of a loved one. Sometimes it could be witnessing one of these events. Sometimes it could even be hearing about one of these events from a family member or loved one. What's interesting to note is that I think the vast majority of individuals will at some point in their life experience a potentially traumatic event, something around on the order of like 80% of people estimated to experience this at some point in their life. However, not everybody goes on to then develop a trauma-related disorder. Trauma-related disorder being sort of, symptoms that develop subsequent to the trauma that end up causing a lot of distress in the person's life and or kind of impairment in their ability to do the things that they would normally want to do in their life. I think estimates are about 6 to 9% or so of individuals will experience post-traumatic stress disorder at some point in their lifetime. So just highlighting there that trauma is very, very common. Not everybody who experiences trauma will go on to experience a trauma-related disorder.
Generally speaking, who tends to be most at risk for developing a trauma-related disorder?
Yeah, so I think there are a number of different risk factors. One of the most important risk factors for PTSD is actually having experienced prior trauma in one's life. So, for example, people who have had a lot of adversity, traumatic experiences in their childhood, situations later in life are more likely to be experienced as traumatic. Kind of circumstances surrounding the trauma itself can impact kind of the way in which it impacts a person. So, for example, if somebody has sort of a lack of social support in the aftermath of trauma, that's a big risk for then developing a trauma-related disorder. And on the flip side, if people do have a lot of support kind of around them, people to talk to, be with, feel safe after what's happened, less likely to go on to experience a trauma-related disorder. Kind of increasing duration of exposure to trauma is another risk for developing a trauma-related disorder. So something that is kind of like repetitive and ongoing as opposed to just a singular incident. Having less education, lower socioeconomic status has been associated with development of trauma-related disorder. Females are estimated to be about twice as likely as males to experience a trauma-related disorder. I think another important piece too is that sometimes the sort of type of trauma can affect, how likely one is to go on to then develop a trauma-related disorder. So things like interpersonal trauma, sort of intentional traumas that are perpetrated by an individual, especially somebody that the person knows, that tends to have greater impacts compared to something like a natural disaster, which is, sort of an accident. Nobody else had control over that. In general, I think, the sort of self-perceived fear of danger or death in the moment of the experience also has been associated with the development of a trauma-related disorder. So kind of how dangerous the situation was from the eyes of the individual who was in the situation.
Before we start talking about some of these specific trauma-related disorders, can you give us the broad overview of what is under that tent, so to speak, the different varieties of trauma-related disorders that we should be talking about today?
Sure. So the DSM, the sort of gold standard diagnostic manual in psychiatry, sort of defines different trauma-related disorders, in part based on sort of when symptoms of the disorder develop subsequent to the trauma. So there's something called an acute stress reaction, which is sort of when somebody has certain symptoms in the immediate aftermath of a trauma, up to 48 hours after a trauma. Then there's something called an acute stress disorder, which is when symptoms kind of appear somewhere between about 2 days and a month after the trauma. And there's post-traumatic stress disorder, which is when symptoms have endured for a month or more after the trauma has happened. There's kind of that category. There's also kind of this idea, which I think we'll get into later, about complex post-traumatic stress disorder, which is not formally in the DSM, but is something that we think about as maybe different from sort of classic PTSD. There are also a number of dissociative disorders that sort of fall under the category of trauma-related disorders because trauma is such a sort of a part of what later leads to the development of those disorders. So I think that's kind of those are the general kind of scope of what falls under that category.
Great. And thanks for breaking that all down. We're going to circle back and dive down more deeply on each one of those different categories of traumatic or trauma disorders. Before we do that, though, I want to take a step back and talk about some other terms that we should be using today very carefully, because words matter and terms matter when we're talking about these very critical categories. Trauma, traumatic event, PTEs, potentially traumatic events. What do we mean generically when we talk about trauma?
So I think a trauma, it's something that really leads to a threat to one's either physical or psychological integrity. So something that feels very dangerous to the person in the moment. And that again, sort of where I highlighted that what that looks like might be different from person to person. So what might sort of be a trauma for one person might not necessarily be a trauma for another person.
And a potentially traumatic event, a PTE, you hear that term kicked around sometimes in discussions about traumatic or trauma-related disorders. What does PTE get at, and what should we know about that term?
I think a potentially traumatic event kind of encompasses like a broad range of experiences that people might have that could potentially lead to that experience of feeling as though one's life is potentially in danger. Again, that can range all the way from kind of, childhood experiences of, physical, sexual violence, for example. It could be those same experiences later on in adulthood. It could be something that doesn't involve another person at all, such as a natural disaster or other sort of accident. So it really encompasses kind of a broad potential range of experiences, and really depends on the person.
So you mentioned this earlier. It sounds like most of us experience PTEs at some point in our life. That's a part of being a human being.
That's right. That's right.
So why is it that some folks wind up developing a trauma disorder based on those PTEs and some do not? I mean, I realize it's a very complex question with a very complex answer, but
Yeah.
generally speaking, why do some folks wind up having longer term, more acute issues because of a trauma related event or potentially traumatic event than others?
Yeah, so I think there are probably a lot of factors involved, and you're right that it's complicated and that I think we don't have exactly all the answers or, exactly have, the ways to predict sort of who going into some circumstance, like who is going to experience the disorder or not. But there are kind of a number of risk factors that we think might make people more or less likely to develop trauma. And that sort of includes things, both things that sort of are within the person, sort of risk factors themselves. So, we think there's probably some genetic vulnerability. So like an inherited vulnerability to experience these disorders when faced with a trauma. And, also, I think I mentioned earlier, also, if one has had other prior experiences of trauma in their life, it makes them more prone to develop a trauma-related disorder from a later incident. There's sort of this idea that there is some sensitization, so to speak, where if one has already sort of been traumatized, they're more easily, again, traumatized in the future. It also, matters kind of what happens, not only, what sort of factors not only within the individual themselves, but also sort of in the immediate aftermath of the trauma. Kind of things like how well the person is supported or not supported, kind of right in the aftermath of what's happened. There's kind of this idea that oftentimes in sort of like a longer term way, that if one kind of intentionally or unintentionally sometimes avoids certain I guess reminders of the trauma, that avoidance ultimately can lead to things kind of escalating, getting worse, getting more over time. I think we'll probably get into that a little bit later, a little bit more.
We will indeed. One of our goals with this webinar series, Heidi, is to weave in questions that have come in from the audience. And I'll be doing that throughout the webinar. One question that came in, I think, touches on something that you mentioned early on. Why might women be more likely to experience a trauma-related disorder than men?
That's a really excellent question. I'm not sure if I know the exact answer to that. I don't necessarily believe it's because women are more likely to experience a trauma per se, so much as it is something else. But I honestly, I'd have to look that up and kind of get back to you, the details of that.
That is a fair answer, of course. Let's talk about PTSD, post-traumatic stress disorder. This is what I think most of us think about when we talk about trauma-related disorders. Definition to start with, what exactly is PTSD by definition?
Yeah, so PTSD, based upon the DSM, that Diagnostic Statistic Manual criteria, sort of has essentially 5 different criteria. So there's criterion A, B, C, D, and E that goes into a PTSD diagnosis. So that criterion A is the trauma part. So, exposure to a trauma is necessary to be diagnosed with PTSD. That, again, can be experiencing the trauma oneself or witnessing the trauma or even sometimes learning about the trauma having happened to somebody close to them. And then there are these different sort of clusters of symptoms that go into the diagnosis. So there's this criterion B, which encompasses sort of what we might consider trauma-related intrusion type experiences. So experiences where, in a way, the past is kind of intruding into the present time. So that might look like intrusive memories about what happened. It might look like something like a flashback where the person, to a variable degree, sort of fully loses track of when and where they are and sort of feels as though they're back in the traumatic time. sometimes nightmares, sometimes kind of just strong physiologic reactions in the body when someone is reminded of the trauma. So these are sort of, again, the criterion B, the intrusion type experiences. Criterion C for PTSD is avoidance, which we mentioned earlier. So it's really, really common, understandably, for people to avoid both kind of internal, meaning inside their mind, and external, meaning in the world, things that remind them of the traumatic incident. So much so that is one of the diagnostic criteria. Of note, I think sometimes avoidance does look like, literally avoiding a specific person or a specific place or activity, but sometimes it looks in other ways too, meaning it can look like things like substance abuse, right? People kind of using substances to numb or get rid of certain emotions. It sometimes looks like self-harm or binge eating behavior. So avoidance can look a lot of different ways. Then there's a criterion D in post-traumatic stress disorder, which is kind of negative alterations in cognitions and mood, which in my mind is kind of a long way of sort of alluding to symptoms that might overlap with major depressive disorder a lot of the time. So people will, develop sort of this persistent inability to experience happiness, positive emotions. They'll kind of be in a persistent state of, fear, horror, anger, guilt, shame, these kind of more negative, difficult emotions. People will develop a lot of negative thoughts about themselves or other people or the world. Self-criticism is part of that. And then lastly, there's this criterion E part of the diagnosis, which kind of is around this idea that the body's still kind of like revved up after what it's experienced. So what we might call hyperarousal type symptoms. So hypervigilance, when the person feels sort of like on guard, there might be danger around them, for example, or having a lot of sleep problems, that would sort of fall under that criteria. So it's kind of all of these criteria would sort of lead to the diagnosis of PTSD.
What about timing of onset? It sounds like that can vary quite a bit with PTSD. What should we know about timing?
It can, yeah. Again, I think trauma impacts different people in different ways, and that includes in relation to the timing of it. So I know we mentioned earlier sort of the acute stress disorder, acute stress reaction. So one wouldn't be diagnosed with PTSD until it has been at least a month after the trauma. For those symptoms that we just mentioned, if they've kind of continued for that duration of time, that might lead to PTSD. Sometimes sometimes it happens quickly that people develop these symptoms right in the aftermath of trauma, and they sort of go on for a while. Sometimes the person sort of seems relatively okay for some amount of time after, even like months, and that can kind of confuse loved ones, even like you just went through something really difficult, like how are you not kind of reacting more? Sometimes it can be like several months later that the symptoms will develop. So there's this kind of specifier criteria called with delayed expression, where it's the symptoms not developing until 6 months or more after the trauma has happened. So it can really look a lot of different ways for different people.
You touched on the issue of misdiagnoses, and a couple of questions have come in about that. Can you misdiagnose PTSD as ADHD or vice versa? Can you have both diagnoses at the same time? Is PTSD often misdiagnosed as an anxiety disorder?
Great questions. I think probably yes to all of the above. It's really, really complicated. There's a lot of sort of symptom overlap, right? Like in ADHD, you have these attentional issues, these sort of tendencies to maybe space out or miss things or lose things. And that absolutely is something that happens as a part of PTSD. And, if somebody is sort of not very thorough in their history taking and sort of doesn't realize that trauma has happened, might sort of lead to an erroneous diagnosis of ADHD, for example. That said, absolutely, these things can also co-occur, meaning one can have ADHD and also experience PTSD. And so they could have, their symptoms could sort of be related to both disorders. I guess sort of similar for anxiety disorders, I think that a lot, anxiety is very much a part of PTSD. And I think, sort of if one doesn't kind of know the entire context, then absolutely, I think it could be kind of called just anxiety, so to speak, when sort of the person doesn't realize the relationship of trauma to what the person is experiencing.
I think you're really painting a picture of a pretty complex diagnostic process.
Very much so. Very, yeah, yeah.
On that note, this question came in. Does PTSD present differently in each person? And specifically, do different cultures experience PTSD differently?
That's a phenomenal question. I will kind of stick to answering the first part just because I'm not so much of an expert on sort of on speaking to the second part. Anyway, I think absolutely, yes, different people, different cultures could lead this to manifest in different ways. So of the criterion that I mentioned, some people have, just the intrusion experiences kind of first and foremost. They present like kind of, mainly with the nightmares and the flashbacks. You might have another person that presents really more so with just the sort of more like depressive kind of like, I'm bad, the world is bad, just feeling kind of persistently negative. You don't necessarily have to have literally every one of the symptoms that I outlined to meet the criteria for PTSD. And absolutely, it does. Sort of people have different different mixes of the different symptoms that I mentioned, but not necessarily all of them. The cultural piece is a fascinating question that I would also have to read a little bit more about to be able to answer.
Let's move into treatment options and how PTSD is typically treated. Can you walk us through that process and what the different options are?
Yeah, absolutely. So the treatment tends to involve, sort of depending on the person's preference, some mix of medication and or psychotherapy. So I guess kind of can start maybe with one or the other side of those. Oftentimes it ends up being the combination of both that ends up being helpful. Although, sometimes people do, just sort of go through psychotherapy itself and that's enough. Not everybody needs medications to be able to manage the symptoms. So in terms of kind of, the medication side of things, there's not, it's very, something like this is very different from, having a pneumonia, an infection and going to the doctor and getting an antibiotic and then, it's gone, you're sort of cured, so to speak. Our medicines aren't sort of going in and sort of curing or fixing an underlying process per se. It is really the therapy process over time that sort of leads to that deeper healing, I think. However, the medications can be very helpful tools to manage some of the specific symptoms that we were talking about earlier. So for example, we have very good medications for nightmares. We have medications that can help manage the anxiety, the depression. So again, kind of using medications to treat kind of specific symptoms along the way while the person is kind of healing over time or healing through the psychotherapy process.
We sometimes hear the term trauma-focused treatments. Can you explain what that means?
So trauma-focused treatment in my mind might involve sort of a psychotherapy that, again, sort of as the name implies, focuses on the trauma and on sort of sometimes that's more, talking in detail about the trauma itself. Sometimes it's less that and more talking about kind of the ways in which the trauma has impacted the person. So I think a trauma-focused treatment would sort of subsume both of those things.
What about expectations for somebody who's been through treatment for trauma-related disorders? Folks can go on and live a very productive life with PTSD?
Absolutely. Absolutely. I think it's something where, again, everybody is different. The impacts of trauma vary kind of from person to person, but absolutely, I would say that there is good treatment out there and that there are people who have experienced trauma and experience, all those symptoms that I mentioned in the aftermath, and then can go on and kind of heal from that and get back into their life. Absolutely.
So many questions for you, both from me and from the audience that's coming in that are coming in right now. We'll keep chipping away at this as we go here. Complex PTSD. We hear that term more and more. Is it an official diagnosis distinct from PTSD? And what does that mean? What does the complex part of that designation mean?
Absolutely. So as the name might imply, it's a complicated story. So complex PTSD it's not a separate DSM diagnosis as of right now, although people have proposed that it should be its own separate DSM diagnosis, and we might see that appear at some time in the future. There's some degree of controversy, I would say, about sort of what complex PTSD is or isn't, but sort of generally speaking, it sort of, some of what we were talking about earlier with sort of classic or simple PTSD, it might sort of happen that there's a single major traumatic incident, and then the person sort of develops those symptoms in the aftermath of that kind of single traumatic incident. In complex trauma, the situation is more that the person has experienced this sort of repeated trauma or trauma in an ongoing way that is tends to be something that is very difficult, if not impossible, to escape from. So, for example, somebody in a domestic violence situation where there's kind of ongoing abuse happening in that relationship, or oftentimes this is something that happens in childhood. If there's childhood trauma, abuse, neglect, that's something where the caregiver, the child has to be with their caregiver, but the trauma is happening, so they can't get away. But it's sort of like an ongoing trauma. Oftentimes, things that are sort of fall under this more complex trauma involves trauma that occurs in the context of a personal relationship. So again, as opposed to something like like a natural disaster, for example, that would sort of land very differently than something that is perpetrated by another person, especially a person who's supposed to be a safe person, right? So a caregiver to a child, for example, that's supposed to be a safe person who's taking care of you. They're perpetrating trauma. That, those sorts of experiences tend to lead to this more sort of complex PTSD picture.
Is the treatment process much different between the two?
In some ways, yes. In some ways, no. I think in terms of the medication piece of things, it's similar in the sense that we are kind of treating target symptoms as best as we can. In terms of the psychotherapy piece, I would say the treatment for the complex PTSD is probably more complicated overall, as one might imagine. We have really, really excellent evidence-based psychotherapies for PTSD, things like cognitive processing therapy, prolonged exposure therapy. Those are treatments that span about 12 to 16 weeks or so, and person can get a lot better in that sort of period of time. When we're talking about complex PTSD, especially when we're talking about circumstances that happened kind of while the person's brain is still developing in that kind of critical time period throughout childhood, that tends to be a much longer treatment process, tends to kind of necessitate like a therapist with whom one can continue working with it over a long period of time.
Let me run another term by you, DID. What does that stand for, and how does it fit into this conversation?
So DID stands for dissociative identity disorder, which is a dissociative disorder that's sort of like on the most extreme end of trauma-related disorders. So dissociative identity disorder it's a disorder that develops when one has experienced very, very severe kind of repeated ongoing traumas starting from a young age. Always that is sort of considered necessary, but not sufficient for the diagnosis for those experiences to have happened with dissociative identity disorder. And there's sort of a number, I'm not sure if we're going to get into it a little bit more, but there's sort of a number of symptoms that result from that. But it's kind of, again, it is a trauma-related disorder because trauma it has happened in everybody who ends up experiencing those symptoms.
Let me weave in a few more audience questions here. We've got a lot coming in here for you, Heidi. Can a minor event or minor accident cause PTSD?
It's a good question. I think this kind of gets into that idea that to some extent trauma is in the eye of the beholder, meaning that what really matters for it to be considered as trauma for the person to later be diagnosed with PTSD is whether the person thought that their life was in danger at the time when the trauma happened. And so, a minor car accident, for example, and somebody, sort of knew they were going to be okay, probably not going to go on to develop PTSD. If for whatever reason, they truly felt like their life was in danger in that situation, it is possible that they could go on to develop PTSD.
A viewer wants to know whether or not children can be diagnosed with trauma-related disorders.
They can. They can. Unfortunately, I think trauma can happen in children more often than we'd like to think about. But I mean, the short answer is that yes, they can.
I want to ask you about supporting a loved one with a trauma-related disorder. It sounds like from what you've shared, a big part of that support is actually coming to recognize the signs and symptoms, the red flags, if you will. Can you provide some more specific guidance on that front?
Sure. So I think in terms of supporting a loved one with PTSD, I think it's obviously important to be there for them, sort of be a safe person for them to talk to. It's definitely not about like pressuring them to talk about what's happened. Sort of, I think things like making sure that they are taking care of themselves, sort of like, meeting the basics. Like, are they, getting their meals in? Are they sleeping? Are they sort of doing the basics of what they need to take care of themselves? Being a supportive person. I mean, sometimes loved ones can sort of be pulled into treatment. Like if somebody experiences like flashbacks, for example, or kind of big dissociative symptoms, loved ones might sort of learn from the treater who's working with that person, kind of what are tools that I can use to kind of help bring that person back to the present moment. That can be another important role for them.
We tend to have a lot of clinicians in our audience for these webinars, and I want to ask you to speak directly to them in terms of what they should know, say a general practice clinician. What should they know about treating PTSD and when it's appropriate to refer out and when it's appropriate to continue with a client on their own?
Sure. So I think that, obviously it sort of depends a little bit on the trajectory of the patient over time. So if things are sort of, some of these symptoms are naturally getting better over a period of time, that would sort of mean that things are sort of okay. I think referring to a professional would make sense if kind of these symptoms are sort of really persistent, ongoing, causing a lot of ongoing distress, or like leading the person to be unable to do what they need to be doing in their life or want to be doing in their life. I think certainly if there are, kind of sometimes safety related concerns can come up in the context of PTSD. So can lead to things like, thinking about not wanting to be alive any longer, for example, right? Suicidal ideation, self-harm behaviors, substance abuse sometimes. I mean, I think that those sorts of things might end up leading one to refer to more specialized treatment. Certainly, if there's sort of ever like an acute safety concern, meaning thinking that the person is actually imminently at risk of ending their life, then that would be a time where one would refer to like an inpatient unit rather than kind of keep going with outpatient treatment.
We've had a couple of questions come in about first responders in that community. It's such an important topic. Let me start with this one. How does PTSD present differently in the context of repeated traumatic events, such as those experienced by first responders?
Yeah, absolutely. So I think that, potentially becomes more of like a complex PTSD-like situation, right? Where one is experiencing sort of like repetitive, ongoing traumas. So that those sorts of experiences tend to, I mean, they can often lead to those similar PTSD symptoms that I outlined earlier, the intrusions, the kind of hyperarousal, avoidance, mood changes. Also, tends to, when one has experienced these kind of prolonged repetitive traumas, they tend to also experience a lot of kind of like difficulties regulating their mood, for example, like a lot of, anger outbursts is one example, or irritability. They might be more at risk for developing some of those kind of safety related concerns that I mentioned earlier. So like self-harm, suicidal behavior, might be more likely to kind of socially withdraw, might be more prone to kind of dissociation, where their mind sort of checks out from being present at all in a way. So, I mean, again, it sort of overlaps with the other sort of PTSD criteria that we talked about earlier, but then sometimes sort of has those additional features as well, I would say.
And one more question that came in on this front, a little bit more specific one. Are there any recommended trainings or resources with a focus on trauma in first responder populations? Or we might ask in another way, is the first responder community getting the training that they need to be dealing with these traumatic events?
It's a great question. There is at McLean, actually, it's called the Leader Clinic, which is specifically a clinic that sort of treats individuals who are kind of first responders. In terms of, is the question more so, are they getting enough training sort of going into what they're doing, or more sort of in the aftermath?
I guess that would be my question, is generally speaking, are they getting the training that they need?
Gosh, I know very little about kind of what sort of training they get now. So I'm honestly, I'm not sure. I certainly think it's possible that they are not, but I just don't know. I don't know the training that they get now.
Fair enough. That makes sense.
Yeah.
Heidi, one thing that would be really helpful, I think, is to sort of walk through a very hypothetical case of PTSD. Could you give us, again, a hypothetical scenario, perhaps somebody who has been exposed to the horrors of war, for example, coming back from combat, what that individual might be facing, how PTSD might present itself over the course of time, and what treatment might look like that for that, both the short term and the long term?
Sure. So, I mean, I can sort of paint a potential picture, but knowing that, again, I think PTSD really looks different from person to person. It's,
sure,
as we mentioned earlier, kind of a complex diagnostic picture, which sometimes kind of looks more one way, like a sort of more like person sort of presenting as more shut down and withdrawn and depressed. It can look like the person being sort of more revved up and anxious. So it really can present a lot of different sorts of ways. So I can't imagine that there's sort of like one picture of how it might look, but for kind of example, so somebody who's experienced that combat trauma comes back home. I could imagine that they are sort of, have a tough time sort of transitioning back into being in the real world, so to speak. Things might feel a little sort of like off or weird or different. They might feel kind of like disconnected from themselves or from the world around them. They might, again, the timeline is really different. So some of these people might experience some of the symptoms we mentioned. They might feel, kind of revved up. They might, if they hear like a loud noise or a siren, they might startle really quickly. It might look something more like that. They might want to sort of isolate at home, avoid even going out into the world and having to potentially face loud noises that make them startle, for example. Could look something like that. It could look something like the person sort of, gets back and sort of tries to keep going about their daily life, and they might sort of look like normal for a time period. And maybe their loved ones don't even notice that anything's amiss, and then sort of some months later on, some of these symptoms kind of might emerge later, that the person is, all of a sudden, like really irritable or, again, socially withdrawn. Again, I think the picture I'm trying to paint overall is that it can just look so many different ways, just
sure.
depending on the person. The impacts of trauma are just really, really different person to person.
And again, just sort of keeping with that hypothetical, what might the treatment process look like for an individual who has come back from combat, for example, with those kinds of challenges on the PTSD front?
Sure. So again, I would say it depends. If they sort of have many of those symptoms kind of, right away, let's say, for example, and they, presented to care, I'm assuming that, kind of whatever specialized care is available in this hypothetical situation. So they might meet with a psychiatrist and be started, say, again, hypothetically on an SSRI for, kind of to help kind of dial the volume down on that really high anxiety or kind of just help manage their mood, a little bit. One example, again, they might be started on medication for nightmares if they're having nightmares. And sort of while those medications are sort of helping the symptoms partially, they might engage in a trauma-focused psychotherapy that could, different, again, we have different types of sort of evidence-based psychotherapies for trauma. And sort of which one is selected kind of depends a little bit on sort of how the individual is presenting. But, hypothetically, the person could, do this treatment, one of the evidence-based treatments that takes about 12 weeks. And, the treatment's hard. I'll say that too, right? We're talking about oftentimes with PTSD, there's sort of this piece of avoidance, meaning that the person doesn't want to talk, think about, see reminders of what's happened. And in the trauma-focused treatment, they're doing literally just that. They're sort of challenging the avoidance and actually talking about the trauma and how it continues to impact them. But, if the person is able to get themselves to do that treatment, they could feel a lot better, after going through that.
Heidi, this is probably a great follow-up question to that because, as you suggested, each case of PTSD is distinct. The treatment options are many. What are the differences in psychotherapy versus therapy with a trauma therapist for PTSD? How do CBT, DBT, ACT, et cetera, come into play for PTSD specifically? There's a lot to unpack in that question, of course, but
Yeah.
What would you like to share about those different forms of therapy and how they might fit into PTSD treatment?
Sure. So I guess I can speak just kind of general overview to like what sorts of PTSD therapies are used, or like what the options are.
Sure.
So for kind of, again, so some of the most evidence-based treatments that we have for PTSD are number one, prolonged exposure therapy, and number two, cognitive processing therapy. Prolonged exposure therapy tends to be super helpful for the people who are kind of have more of that like hyperarousal, kind of revved up, anxious type of presentation. And it involves sort of repeatedly kind of intentionally revisiting the trauma memory. And while that is something that is, person maybe is inclined to avoid initially, once they kind of can move through it rather than avoid it, and sort of digest what has happened, process it, so to speak, that can be really, really helpful over time. The memory, the impact of it can kind of lessen over time. The cognitive processing therapy is a more sort of, as the name might suggest, sort of like thoughts or cognitive based treatment where, it's sort of a really good fit for people who, we often sort of see post-trauma that like people sort of thoughts, their narratives, the way in which they think about themselves or other people or the world sort of changes after the trauma. Or they have thoughts like, well, I did something wrong that this happened to me. And cognitive processing therapy sort of gets at some of those thoughts and sort of tries to challenge them and kind of lead them to a more balanced view of things, so to speak. So there's those treatments. Those two treatments, the prolonged exposure therapy and cognitive processing therapy, are both sort of under the general umbrella of CBT, cognitive behavior therapy, meaning therapy that's sort of focusing on kind of this interplay of thoughts and feelings and behaviors. There are some other evidence-based trauma therapies as well. There's like a written exposure therapy. There's a transference focused psychotherapy. There's a number of different options. I think you mentioned something about DBT, dialectical behavior therapy, which is really great to sort of, I think, weave into trauma-focused treatment, because it sort of focuses a lot on kind of emotion regulation and distress tolerance. And that's something that, again, in PTSD, oftentimes there are sort of these like mood fluctuations that happen. And so kind of learning how to manage those can be really helpful. Learning how to, be able to talk about really difficult things that have happened without needing to run away and avoid it and use substances, for example, instead, can be really helpful. So DBT can sometimes give people those skills to be able to do the other, forms of trauma-focused therapy, for example. There's also, there's sort of more, for the more complex PTSD or something like DID, where, again, there's been really severe, prolonged, repetitive trauma starting at a young age. We're not talking about, 12 weeks and then the person is done and feeling better. That's something where they're going to be forming, hopefully, a good relationship, a safe therapeutic relationship with a trusted provider, and working through things over really a number of years often.
Great job breaking all that down. You covered a lot of territory right there. And again, speaking to the complexity of this topic here, question came in about generational trauma. Is there a genetic connection? What are we getting at when we talk about generational trauma?
I think generational trauma, in my understanding, is sort of a few different things. So it's sort of this idea that, like, if a grandparent or parent has experienced trauma, that sort of manifests sequelae of that experience could be sort of passed on to their children, to their offspring, and that I think there are probably a number of different factors that might sort of be involved in that. There might be partially a genetic basis, meaning, again, we think there's sort of some inherited predisposition to experience these sorts of symptoms in the aftermath of trauma. There's also, the sort of this idea that, like, if a mother, for example, has experienced a lot of trauma in her own life, she hasn't necessarily learned the skills to manage her own emotions, for example, and sort of, her behaviors that develop as a result of that might be sort of passed on to her child through modeling or through how she interacts with the child, for example. There's also sort of this idea that intergenerational trauma might be mediated through something called epigenetics, which is where sort of like it's the way in which environmental sort of lived experiences end up impacting our genetics, or sort of impacts the way in which our genetics are expressed, essentially, which is kind of interesting to think about. There's been, I think, some studies that, suggest that there truly are like epigenetic changes that kind of can be partially responsible for the generational trauma.
But a couple questions come in specifically about EMDR and the treatment of PTSD and CPTSD. Can you define that term for us and talk to whether or not this is something that's a part of the mix for treatment?
So EMDR, eye movement, desensitization reprocessing, I believe is what it stands for. There's some degree of controversy out there about EMDR and sort of, how it sort of stacks up to the other trauma treatments. I am not an expert on EMDR, and so I don't want to speak too much about it. But I will say, in kind of my understanding of it, something that EMDR does ultimately include is sort of the challenging of avoidance of kind of trauma-related matters, right? So I think it's really, really important to highlight that kind of the ongoing avoidance of certain thoughts, feelings, behaviors, places, people, things, kind of keeps PTSD alive in a way, and the challenging of that avoidance and working through the emotions, the thoughts, the feelings is what really ultimately helps people heal from PTSD. And I think EMDR, does sort of incorporate elements of that, of challenging avoidance, of moving through, rather than trying to avoid the trauma. So sort of leave it at that, I think.
Heidi, as our time starts to wind down here a little bit, I want to ask you a couple of broad questions. One would be misconceptions, and there are a lot of misconceptions around trauma-related disorders and PTSD. What stands out to you, and where are we trend line wise, if you will, in terms of whether awareness is helping break down some of the stigma around PTSD as well?
Yeah, I mean, I think that, I think we've definitely come a long way and also have a long ways to go, meaning that I think that, some decades ago, PTSD was, as you alluded to earlier, very sort of associated with, combat veterans. And I think that, that those sort of experiences of people who came back from the war is really sort of what started to kind of bring light to the fact that like trauma and trauma-related disorders are a real thing that people experience. But then in subsequent decades, we sort of started to realize more that like it's much more than just combat that can lead to these disorders. It's a number of other different sorts of experiences that can as well, including early childhood experiences, which again I think is something that in the past people have kind of shied away at looking at, because it's a setting, I think, to think about children experiencing certain things. But again, I do think that kind of more like research in recent times is being done on, people who have experienced kind of severe early life trauma. And I think there is, I think we have a ways to go still, and there is definitely more light sort of being brought to it than there used to be.
What's happening on the research front with PTSD and trauma-related disorders? Are you seeing some promising research out there?
Yeah, I think absolutely. So there's some research happening right at McLean, including, a lot of different sorts of research. There's research looking into, for example, like neuroimaging. So what are the brain changes? What can we see on a brain scan? And there are some, like there are, this is a sort of, we call it like a psychobiological syndrome. Like there are sort of biological correlates to what the person is experiencing when they experience PTSD. So there are studies sort of looking at that. I think maybe one day that's sort of not in clinical practice yet, meaning that you wouldn't go to a clinician and be referred for like a brain scan typically for clinical reasons. But hopefully maybe in the future it might sort of help us sort of clarify things diagnostically. A lot of treatment-related studies, certainly both in the psychotherapy front and in the medication front. I think there's a lot happening. I think that things will continue to learn and feels hopeful. Yeah.
We'd be remiss not to ask you about resources that we can pass along to our audience in terms of learning more about trauma-related disorders, PTSD in particular, perhaps websites, books, anything that you'd like to share that you think might be helpful for someone looking to educate themselves on this topic.
Sure. I think the best resource that I would point people to, and I guess you'll post this on the website as well, would be the ISSTD, the International Society for the Study of Trauma and Dissociation. Their website is excellent, has a number of different resources, both for patients, for providers, for caregivers, and there's also sort of like a find a provider resource on there where you can, search for a professional who has some expertise in trauma and dissociation. I think that would be kind of the number one resource.
Excellent. And then finally, we like to wrap up these webinars on a very positive note. And you've shared a lot of reason for hope throughout the past hour as well. But I'd love for you to speak to an audience member right now who might be feeling a little overwhelmed by this whole topic and the challenge. Can you speak to the hope that is afforded through treatment? As
somebody who has the privilege of treating people who experience trauma, I've seen it time and time again that people get better through treatment. I think it's so helpful, important for people to know that they're not alone with these experiences. I think sometimes having had trauma and then having had these really difficult thoughts, feelings in the aftermath of trauma can make people feel very alone, but you're not. There are other people who are experiencing similar things out there, and absolutely there's a lot of hope. if, it's hard, it's very hard. It's hard to sort of take that initial step of getting treatment, because that sort of, it sort of necessitates starting to challenge some of that avoidance that is so understandable. But yes, if you can kind of get yourself to that initial push to treatment, I think that there's a lot of hope for people. Absolutely.
It's a great place to wrap things up. Heidi, I can't thank you enough for your time today and your expertise. You've done just a fabulous job of running through a lot of very complex material for us. We'll have to pick up our conversation down the road, but thank you so much for your time.
Thank you so much for having me. Thank you, Jeff. Thank you all.
And to those of you watching, thank you for your interest in our educational webinar series. We hope you'll come back to view more of our future sessions, and we wish you a wonderful day.